Good afternoon, everyone, and thank you for attending another ACAM's eMedTalk with Dr. Ahvie Herskowitz, President of ACAM. Today's title, State of the Art, a COVID Pandemic Update. So attendees are encouraged to submit questions using the chat box over to the right of the screen. As you can see, I've already posted a message in there. So any questions, feel free to post them there, and they will be addressed at the end of the update. So next, I have the pleasure of introducing Dr. Ahvie Herskowitz. So he's, as I mentioned, the president of ACAM, international leader and educator in the field of personalized precision integrative medicine. He has a diverse academic background that touches not only in cardiology, immunology, and autoimmunity, but as well as virology. And his most recent academic position was as a clinical professor of medicine at UC San Fran. So, Dr. Herskowitz, I pass it off to you.
Thank you, Jordan. Tell me, okay, it's time for me to okay, we'll start with your administrative thing. I first wanted to say hello to everyone on the webinar. I want to say hello to all my colleagues and friends. I also wanted to first talk about the ACAM annual meeting that's scheduled to take place in November, on November 12 and 14 to 14. That's a Thursday afternoon, all day Friday, and all day Saturday. It'll be all virtual, which gives us a lot of flexibility. And we have a lot of luminary speakers, including Daniel Amen, Dietrich Klinghardt, Neil Nathan talking about mold, and Pamela Smith, the director of medical education at A4M, as well as many others. This is going to be an up-to-date type of a meeting. It'll be relevant to the times. You'll look at the agenda, and the agenda will be added to over time depending on what our environment looks like. I think that when we anticipate what our medical environment, our healthcare environment is going to look like in November, one can only guess. And while I'm fairly certain we'll have a tremendous amount of data flowing into the mainstream on vaccines, on the interaction between the flu vaccine and the presumed COVID vaccines, safety, efficacy, therapies as they come along, I think that we all want, as an ACAM community, to stand together. I also want to thank all the collaboration cures folks that are on the call. As you know, ACAM's meeting will be in collaboration with AAPMD, our colleagues for the last few years, and I want to thank them for their support in having me do these updates. This is the sixth one that we're going to do today. But again, the main reason to get together in November is not only to get the most up-to-date information in integrative medicine, as many other organizations are also going to do, but also to make it relevant in terms of the science and the public health impacts that are going to be felt throughout our society. And I promise you that that's going to be the case. So I want everyone to consider registering right now. To make this the most innovative meeting, we have to add content. And we intend to do that as time goes on and do it in a timely fashion. So right now, we incentivize you all to register by giving you access to prior state-of-the-art lectures that we have in our library. I think that's a great way of catching up and keeping up with the prior lectures of excellence. So I'm going to get started right now, and I'm going to go into my share mode. I hope this works out well.
Yep, just hit that hide as the last thing.
Is this okay?
Yep, just hit that the word hide if you can see that.
Yes, I can.
Yep, and we're good to go.
I think we've been doing this roughly once a month or so. This month is no exception to the tremendous volumes of information that are out there. You can find some of it on my own website, but we took much of it down at the behest of the government. But also you can catch some of the prior lectures on YouTube and so on. There's also an Understanding Stem Cells website that I put forward to support those of us that work in regenerative medicine, because that's also being put under scrutiny and under duress. And all that site does is meaningfully summarize only clinical trials data. So it's all data driven. I think it could be useful to anyone who wants to know what has already been published in the field of stem cell and also peptide therapy. Now I'm going to tell you first that I'm coming to you from what seems like the red moon of Mars. It's like this in San Francisco right now. We have a very unusual red sky from the lack of sun being able to penetrate the high clouds, as well as the fires throughout Northern California. And it gives a surreal look to the place, which is consistent with our entire experience throughout the entire country. So let's get started and see where we really are. Up to date now, as of I think yesterday, we had around 195,000 deaths. It's about 1 every 1,700 Americans, and roughly some odd percent of our total annual death rate. But if you look at the fourth bullet, interestingly enough, we haven't yet reached the capacity that we reach typically every year with regards to pulmonary disease. So last year in 2018, 2019, we had 225 some odd thousand deaths with lower respiratory tract infections, flu, and pneumonia. And that is roughly 8% annually every year. So the questions that we're going to try to understand today is whether or not there are any excess deaths from COVID, and whether or not, and where those deaths are coming from. But by the end of the year, we'll certainly rise to above 10% of our annual death rate. So the estimate is going to be somewhere around 260 to 300,000 deaths. The question is, are they excess deaths and what the deaths are due to? But they're around, ultimately, it'll be less than half of the annual deaths from cardiovascular disease and from cancer, just to put things in perspective. So this comes straight from the CDC data set. I'm not sure exactly what the color coding is, but there's a few important things on this slide. There are basically 1 in every 3 or so Americans has had a test, and then around almost 8 million positive tests have been identified, with an overall positivity rate of 8%, or 1 in 12 people. And but the color coding is interesting here, and you notice that there's the cluster in the Northeast, and that cluster drove our pandemic, so to speak, when it first arose from the middle of March until May, and largely paralleled the experience in Europe. And now we have this thing going on in the southern part of the country, which is largely responsible for the ongoing cases that are happening. And we want to delve into that because we really want to understand the natural history of what's going on. But if you keep in mind this number of 7.8 million positive tests, that'll be important for the next slide, which is how many actual cases there have been, how many persons in the United States. Roughly 1 in every 50 some odd people has gotten COVID-19 proven by PCR testing, and that means that 1.5 million people are getting repeatedly tested, versus the slide before that showed 7.8 million. But roughly 1 in 50 people have it. The question is, what does that mean in terms of infectivity? Well, which is a whole different story than whether a test is positive or not. We'll get into that at the end of the lecture today. Right now, there are about 40,000 new cases a day, because we're testing quite a lot. And I think there's a new word now in the vocabulary, and that's case-demic, and we'll address that also today. But roughly about 40,000 cases a day. If you take that into account, we're going to end up with 10 million cases in the United States by the end of the year if we use that as a general trend. So right now, there are these numbers of cases. There's 36 some odd, almost 40,000 new cases a day with a 3% overall mortality rate. And just for our California crowd, this is roughly, we're at 1.8% now in terms of our mortality rate versus our cases. This is roughly about half of the mortality rate that was seen in European, the EU countries when they first had their large cases, their large surges, right before we had our surge in the Northeast. Now, the question is, well, what are these deaths due to, and what's really going on? And this is going to be an ongoing challenge. But in the CDC's data, 6% of all the COVID deaths were only COVID. Were only COVID. They were unrelated to any other cause of death. And then on average, of the other 94%, we had some 2.6 additional conditions or causes per death. I'm not familiar with the absolute definitions of how one was supposed to elaborate cause of death in this particular pandemic, but there is a case to make for some bias with regards to people who were found dead at home, people that were found with multiple conditions, with a fever and COVID positivity. That's not going to be able to be resolved by any one of us easily, and I'll explain in a minute why. The main reason why is because of the clustering of the comorbid conditions, and you see here that the majority of the things on the left side are related to cardiometabolic syndromes, and which are really inflammatory states. So whether it's hypertension, obesity, diabetes, cardiovascular disease, and until you get over here, there is nothing on the pulmonary side. Around 1 in 5 patients had a pulmonary condition, and 1 in every 8 people had some kind of asthmatic condition. But it's really pales in comparison to the number of patients that were listed as confirmed COVID cases, hospitalizations that also had inflammatory state, which we know as integrative doctors are associated with these cardiovascular and metabolic conditions. And the reason that makes it even more difficult to tell what mortality is really due to is because, I'll get to it in a few minutes actually. So before I do that, I'll say that while 94% of Americans had other comorbid conditions, 99% of the Italians had other conditions. And it's summarized, I think, in the next slide, where the 48, almost 50% of those patients who died with COVID also had 3 or more other chronic illnesses. A quarter had 2 and another quarter had 1. But less than 1% had no other conditions. So it's very, very difficult to tease out the difference between the primary cause of death versus a secondary cause of death. And this has been well played out in the media and in our own conversations that we have with each other, because we all know patients with pre-existing hypertension, diabetes, age 85, and so on in nursing homes that have passed away, unfortunately, that are difficult to presume to be directly related to COVID. And why is this the case, that there's such a predisposition to this cardiometabolic set of patients, and the immune dysregulation that happens when you get pulmonary involvement and go into cytokine storm? And that's because the unique method of entry into the body via the ACE2 receptor, and I'm not going to get into the the molecular details here. It's just to remind me to say that this is unlike other flu-like illnesses in that sense. It has a different entry point, which is so pivotal in terms of modulation of multiple systems, including metabolic, cardiac, vascular, immune, and hormonal systems. But also because it seems to have not necessarily followed the usual flu-like seasonality. Remember, we didn't get this pandemic didn't start in the United States until March, and we know that our flu season coming up will probably peak in December, January, and February, and then disappear by April. So it has a different type of kinetics to it, and a different natural history. And this is the reasons why, because it has this receptor has powerful anti-inflammatory and modulating effects. And when these levels are reduced, these benefits are gone. So if you have your elderly, tends to be elderly population, tends to have a population that has other comorbid conditions, when you lower that anti-inflammatory or pro-modulatory effect that this receptor has, you can easily go into what I call a chaotic state, but others call a cytokine storm state. And while pre-existing conditions are listed here, the interesting feature is that there is not a lot of COPD patients that we would have thought would have been the primary pre-existing condition, and not as many cancer patients as we had thought, and even fewer of the immune suppression patients than we had normally would think would be at risk of death from a very virulent virus, which is we're grateful for, and we're also grateful, very grateful, and pray that it continues, that our youngsters are seemingly quite protected. And so COVID makes all these disorders worse and gives many patients, it takes them over the tipping point, it can't be reversed. So here we are today. So from all causes, it's actually 2.9 million. Heart disease is roughly 24%, and cancer is 22%. And we're going to hover around half when we ultimately get to the end of the 2020 year. Although again, it's not clear what this row really means at this point. When you look at our prior years, the combination of chronic lower respiratory disease as well as influenza and pneumonia, the combination of which is roughly going to be the same as the COVID years. So this slide I've shown before, and it really just emphasizes that 80% of all the deaths. This slide was made in about 2 months ago, but it's seemingly identical today. It's 80% are people above the age of 65, and when you count the above 55 group, you end up with 92.3%. So only 1 in 12 people that have died of this syndrome are in the age group below 55. The extraordinarily low numbers for the younger population under the age of 24 has to be noted, of course, because these include all of our students up through college and early graduate school. So they are seemingly protected. So then you've seen this slide, I think, many times before as well. And I just want to make a few points. So now it sort of seems, when you look at the United States here, it seems to be somewhere in the middle of our European colleagues, although they were hit hard first. Now, when I'll show you in a few slides from now that the Europeans got hit hard first and are now roughly over with their surges. They're roughly flat at this point. Whereas in the United States, we have two different patterns, one surge in the Northeast and then the other surge for the rest of the country, but primarily in the South. One thing that cannot be easily explained is why Germany has done so well. relatively speaking, to all the other European countries, and why the Asian countries have done so remarkably much better than our Europeans or our folks in Northern America. And it's unclear whether genetics plays the major role, immune genetics, whether the virus was fundamentally different or not. It's unclear. One thing that isn't on here is Sweden, which I'll describe in a moment later, because everyone is fascinated by what's happened in that country with relatively few guidances against lockdowns. But also I want to emphasize how much worse New York was than anywhere else on earth, and that we didn't have much of an option except to respond in a very dramatic way when the entire Northeast was hit so hard in the initial wave. So this is a slide that takes a minute for me to digest for you, but keep on moving the slides. So when you look at the second set of rows all the way across to the right side, Spain, Italy, France, UK, Belgium, Netherlands, and Sweden, you notice that there's a big gap between the first column and all the other columns. So that's the big break that they had in April, when we started to emerge in New York and the Northeast. But there's then after that, though, from what's now listed here as our sort of close to our Memorial Day, in Spain and in Italy and France and UK, the Belgian, Netherlands, and to a certain extent, still even in Sweden, they're flat. So they have their rapid rise in deaths, and then they have been relatively flat. Whereas in the United States, the pattern is somewhat different, and that goes from a huge rise, a tenfold rise in deaths from April to May, and then just an incremental rise between July and now in September over the last 3 months. Again, not flat, but relatively flatter than it was before, indicating that there's something else that should be interpreted as to the kinetics of the way the virus is spreading in the United States. So this is one of my favorite slides to go over. This is a slide that looks at new deaths on average for the week from March to the present. And it's highlighting two countries. Sweden is the surrogate for all of Europe. I think it's an interesting one because they did not go into full lockdown. But you notice that we have somewhat of a parallel. This is normalized by population. So we have somewhat of a parallel set of surges early here. They're higher than we are here. And then around 2.5 months ago, sometime in June, we converge and then we go in opposite directions. So when you look at, they have the one hump pattern, which is identical to all the other European countries. All these other dots here are all the other EU countries that all peaked higher than us and now are all flat. And so we have this double hump, and the first hump is all the Northeast, and the second rise after July 4th holiday is typically, is centered in the South, but not exclusive, obviously. But we have two different patterns, and the other important thing to note is that the peak death rate in the United States, normalized by the population, was about twice as high when the epidemic first started versus the second sort of pattern. I do not want anyone to call this a second wave because I don't believe it is. I think it's a different pattern of infectivity for different parts of the country with a different pattern, whether it's due to mutations or it's due to environment or it's due to humidity or temperature. No one really knows at this point. But the key is that the Europeans are basically done with the pandemic in terms of the first wave. So unless there's a second wave there, outside of the small numbers of cases, that they're already done. And we're going down now but that trend hasn't been fully seen yet. So when you look at the numbers here, our peak was significantly lower than the Europeans by population. This is deaths per million. I mean, the US is 4 times less than Belgium and twice less than Spain and France and the UK. But now, look at that, they're down by 100-fold, 50-fold, and we're down roughly by 60%. We still have quite a lot, and we have significantly more deaths per million than all the other EU countries, and that's because we have a second pattern. This slide is just to remind one, instead of reading the whole thing, I just want to make a few points that no matter what time in the pandemic you choose, whether it's the first month, the second month, third month, or the sixth month, if you choose the top 5 states, they're driving 50% of all the deaths in the country. Right now, cumulatively, it's still New York and New Jersey, and they're still the number 1 and 2 because of population. And now the emerging cases are really in the South, the Florida, Alabama, Georgia, Texas, and Arizona. But in any case, whichever time point you choose, if you model the number of cases that if the whole country followed that pattern, you end up with a tremendous number of deaths that you can model. And if you model the country from the number of deaths from in the bottom 45% of 45 states, you end up with a lower number than a significantly lower number, usually about a third of the upper number. So we had no choice but to address the pandemic when it first came. But this is a function, this divergence between the high risk states and the low risk states is probably a function of the lack of a federal mandate. At the same time, it also may be unrelated completely to lockdown strategies, as we'll discuss in a few minutes. So here you go again with that double hump, the thing back in April and May. If we had maintained that level of mortality, we would have almost reached 800,000 cases in the 12-month period, which was clearly unacceptable. But within a 60-day period, we went down by Memorial Day and even further down by July 4th. And then you get into the summer months, the hot months, with the large gatherings, although the large gatherings, again, may have nothing to do with this rise, but it's a different pattern. And this pattern is roughly 1/2 to 1/3 the pattern that we had initially. But right now, we're estimating with the current state, unless this drops dramatically in the next few weeks, which it may very well, that we're roughly going to end up with around 300,000 deaths related or associated with COVID. And we'll describe what that means in a few minutes. So again, for some period of time after July 4th, we went up and then we've come down, and we're back down further than where we were in July 4th. But the summer was a scary time for the United States, and still leaves it somewhat uncertain as to what our future is going to look like for the rest of the fall and winter. When you look at the numbers of cases versus deaths, of course, when we first began back in March and April, we didn't do a lot of testing, even through May, and we didn't start ramping up testing dramatically until June. But when you look at the number of deaths, of course, peaked in April and May, basically from the Northeast, and then hold on. But so they're basically tracking right now to a certain extent, although our level of testing is dramatic. But you notice that this is a much flatter curve than the one that we experienced before. So right now it's relatively flat, despite the fact that we were testing quite a lot and now we're testing less. So there is no definitive pattern here. In terms of peaks in deaths, and in this case, new deaths per day. It looks like a sawtooth pattern, and that's the pattern that I don't want to get into right now. But it's really a delay in reporting. So this is interesting because when we first began in the Northeast, we were overwhelming our hospitals, and so we had the peak hospitalizations per day. And now after July 4th, we've started having the second peak. And you'll remember that despite the hospitalizations being roughly identical between the first 2 months and the last 2 months, we have less than half of the mortality. So that could be a function of better treatment or a function of less illness. So that is unclear at this time, and I suspect it's a function of both. But there is a discordance now in terms of mortality rates that we're seeing throughout the country. Well, I was moved by an argument that I saw written in one of these YouTube videos that said that despite the fact that we have all these COVID-related deaths, that we actually had fewer excess deaths than we had normally had. And I thought that was really significant because that would mean basically that the virus itself doesn't add anything to the mortality. It just changes, it just shifts it. But it doesn't seem that that's the case. This is from the CDC website that showed the last viral epidemic that we had, the last flu that had a significant number of deaths was back in December, January, and February of 2018, basically 2 years ago. And it showed a few extra deaths for those few months in the midst of the virus itself, the flu. And then we're actually lower than anticipated. And then starting in March and April, we start peaking here. And then, so we do have what the CDC reports as extra deaths. And it's pretty clear. And again, it's in two different humps, one about twice as high as the other. And the question is, well, who are these people and what's going on? And I could say that the way CDC reports it, at least to the individual that doesn't have a special public health account, is quite confusing. But this is what I could glean from it, and you'll have to bear with the next slide. So basically, up until March and April, there was no extra deaths at all, like you saw in that graph. But by early April, it's a surge, and when you look at the causes of death, they're markedly increased in ischemic heart disease, cerebrovascular disease, in this case dementia, hypertension, diabetes. And all of those are much larger in terms of upsurges of extra deaths than influenza compared to the 5 years prior. So the first surge that we have of extra deaths, at least the way CDC combines these deaths, seems to suggest that those extra deaths are all cardiovascular and metabolic, and by a log factor higher than the extra deaths from pulmonary disorders. And in fact, as of mid-May, there are actually fewer influenza lower respiratory deaths than in prior years, and significantly greater other deaths in terms of ischemic heart disease, dementia, hypertension, diabetes. So when you add them all up, even in the first 2 months, we already get 120 to 130,000 extra deaths, and that was pretty much the number that we had experienced with the first surge in the Northeast primarily, and the great majority of them don't include pulmonary disorders. So what does that mean? It means that, to me, that it's unclear what the contribution of the COVID is, and it has to be fully articulated and fully demonstrated almost on a case-by-case basis. But of course, we all know that there were significant cases of ARDS throughout this pandemic, and those get the most attention. The question really is whether a large portion of the population actually experienced that as their cause of death. It's just not clear, and it's really frustrating not to be able to answer that pivotal question, like how many of these extra deaths are truly related primarily to the fact that you came in with upper respiratory pneumonia and so on. So right now, this is the model. The model is we were going to go down, and then we're coming back up, and now we're going to hover between, at the current rate of deaths, the daily deaths, we're going to hover at 300,000, or roughly 10% of our annual mortality rates. So I want to take a few minutes on therapy and tell you what's up. Some of the key points. You cannot review everything. That's why I also want to make sure that everyone in the audience understands that we're going to take the COVID subject in the annual meeting in November very seriously. And while it's not on the agenda right now more than an hour or two, there'll be significantly more material presented there, because the issues are surrounding yes or no for vaccines, yes or no for flu vaccines, and so on is going to be front and center in our everyday lives. So let's talk about the issue with regards to the vaccine. And this is, I think, one of the primary discussion points all over the country. I have some news that happened in the last 48 hours. But I first wanted to show a slide I showed about 3 months ago, showing the consortium of companies that were gathering and meeting with government officials to plan the strategy for the vaccine development. This was going to be an enormous effort, but obviously a needed one if there was a true pandemic. At the same time, I thought that the structure of it was discouraging in some ways. So right now we have one of the major vaccine trials is on hold, as you probably all may know already. The Astrazeneca vaccine now has its second case of transverse myelitis. So for those of you that have medical backgrounds and so on, you'll know that transverse myelitis is fairly rare. It's an autoimmune condition. It's frequently associated with viral infections, but is also associated with autoimmunity. And the most common autoimmune condition is multiple sclerosis. Well, they had a case in July that stopped the trial in early development, in early phase 1. And then when they said, quote unquote, they restarted the trial because the patient had an unrelated neurological illness. What that meant was the patient was diagnosed with multiple sclerosis. And now they have a second case of transverse myelitis. And the Safety and Data Monitoring Board is going to be meeting now to discuss it. This is supposed to be an independent board, and this would be a worrisome finding, because this study is limited to, I think, age 18 to 55, so it's relatively healthy people. And if it's eliciting an autoimmune reaction, then that would be one of the key things that we should be concerned about as integrative society. There's also a lot of downplaying in the media about the side effects from these particular vaccines, because if anyone has taken the standard flu vaccine, you know that you have a little pain and tenderness at the flu shot site, and you also may feel sluggish with a little fatigue and low-grade fever for a day. But these symptoms seem to be a little bit worse, more on the moderate side rather than the mild side. And they have to now initiate it, and in most of these vaccine trials, the addition of high doses of Tylenol to modulate the chills and the fatigue and headache. And the pain at the injection site is seen in about 60 to 80% of people over a matter of days. So there seems to be more of an immunological reaction with this particular set of vaccines, at least in the early part. But we don't have, other than that serious adverse events in those two patients with AstraZeneca, we have not heard much on the more serious adverse events, but it's something to really closely watch. So one of the things that those of us that understand what an inflammatory state is and know how to modulate it was very difficult to understand was how come we weren't treating patients with anti-inflammatories. And this math protocol was designed by intensivists throughout the country, and start treating patients with intravenous steroid therapy, and then high doses of vitamin C, and then vitamins, including vitamin D and zinc and thiamine, and then also gave them anticoagulants because of the clotting disorders that were recognized right away. And these were published in small, relatively small trials, but were very encouraging. And it took basically the private sector, the private hospitals across the country, and individual hospitals to take the leadership, because the CDC and NIH did not take a leadership position with this. And it's still being used in a relatively, it's not the standard of care throughout the country, but it's highly likely that this will be shown and proven over the months to come to be a highly effective strategy to minimize death, time in the ICU, and time and need for intubation. This is a collection of all the different trials that were run for corticosteroid use in terms of mortality, and if you notice, anything that favors the use of steroids for less deaths would be on the left side, would be moving on the left side, and you notice all these dots are on the left side except for one. So out of the 10 or so trials, there's 9 of them. The great majority show a benefit. And this benefit needs to be standardized throughout the country. And then other smaller trials with using different steroids, in this case dexamethasone. But these are cheap generic medicines that are used every day, and intensivists know how to use them. Then we have if you have an ARDS syndrome, if you have pulmonary inflammation, then you'd think that an inhaled steroid would be effective, particularly early. And this is what the data are showing now. This is around 2.5 months old, back in June, that you could inhale any variety of different steroids and get less inflammatory states. So this would be a more rapid control of your oxygen levels that are dropping. And more data are appearing every month on these types of anti-inflammatory approaches. The one thing that's had more information now than ever before is the convalescent plasma, and this is where you pherese out, you put the blood, you collect the blood through an apheresis device, and then return the blood back to the patient. This is a patient that has had COVID and has recovered in the first few weeks with high levels of IgG and IgM and neutralizing antibodies, and then it's given to the ill patients. Now, this has been granted emergency use authorization through an investigational new drug application by the Mayo Clinic, and used in tens of thousands of people to date. There are small trials that have come out that have shown benefit. One thing about convalescent plasma is that it is extremely safe to use even in quite ill patients. So it's something that, God forbid, anyone would need it, is going to probably be useful. But the question is how to get to the people before they ever need that type of rapid and definitive type of care. So we had the best chance we had, I believe, was in the chloroquine family, the hydroxychloroquine in combination with zinc, and in this case with azithromycin, that was initially touted in France and then sort of disappeared from the landscape, and then got heavily controlled in the US, where the average patient or the average doctor could not have access to it. And then that was validated back in May in the Lancet, and then ultimately in the New England Journal. And that was disappointing, to say the least, for those of us that had very strong experience with using it quite early as an antiviral. Well, then the two major publications came under scrutiny, and those two publications were rejected for their accuracy. So we still have only relatively small studies that show that hydroxychloroquine and azithromycin. I would say that it's required to also use zinc as in this cocktail, to show it in very large numbers, and there are conflicting data. But when you use it late, it's not a rational idea. If you use it early, it is much more rational. And then there's so many anecdotes, and yet it's still not the standard. It's much more the standard of care now in Europe and throughout Asia, but and in many places in South America, but it is not the standard of care here today. And I suspect if I ordered it for you today, I might still not be able to get it. Now, the standard of care is remdesivir, which had very modest and very disappointing results, but this is the standard of care in the United States to be used in hospitalized patients, despite no evidence yet that it reduces mortality. And this was again part of the whole mess of combining politics with data and touting data before it was fully reviewed. But in this case, it seems to be a relatively safe drug to use, and maybe saving some lives. We hope so, because our mortality rates are going down. If they're going down, they're going down much more because of the math protocol and much more for other reasons than they are because of remdesivir, but it is a reasonable thing to consider. So if most of the patients are dying from inflammatory states, whether they're primarily in the lung or on the vascular side producing clotting, or they're on the heart side producing damage to the heart, then what is a rational modulating strategy? Well, there's a whole list, and I think that many of you in the audience know the list quite well. This is a summary of things that I don't even think that the bolded things are necessarily more important than others. But I'm going to review a little bit more on vitamin D because there's a fantastic controlled clinical trial that just came out a few days ago. But it's rational. Vitamin D, immunoregulatory hormone, vitamin C, anything antioxidant, antiviral, and so on is on the list. And then I still believe, and I still have a cluster of my autoimmune patients on hydroxychloroquine for years now that will testify to how safe the hydroxychloroquine can be. And of course, all the others that are listed there. On the bottom is the serious medicines for real serious cases, the intravenous vitamin C, just like the dexamethasone, the biologicals that are going to all be published in the next 6 months. These are the immune modulators that we typically use for autoimmune disease, like IL-6 blockers, IL-1 receptor blockers, as well as the peptides and the stem cells. The stem cells will be summarized in the understandingstemcells.com website over the next few weeks, because many investigational new drug applications or IND applications have already been approved by FDA to study the use of stem cell therapy in the sickest of patients in hospital with encouraging early results. But we'll await the publications of those. But it was a good thing for overall for stem cell therapy to be given a new breath on life in the United States based on its potential benefit here. Well, this was a slide I showed, I think, last month. It's hard to review, but there are so many different pathways involved that all need to reflect some intelligence on immune modulation, intelligence on on sparing the lining cells of blood vessels as well as the lungs, and they're all listed here. And I think that you'll find it on the ACAM website shortly. So vitamin D, we all know, is not a vitamin, it's a regulatory hormone. We know it has a lot of different immunological effects, but I wanted to say that we know that African Americans and Hispanics are predominantly targeted by this COVID pandemic in terms of mortality rates and hospitalization rates, and by a factor of 4 or 5 versus the rest of the population in the United States, and the numbers are for our vitamin D deficiency in the United States are quite staggering. And since vitamin D is also associated with the greater risk for heart disease, diabetes, and all these other things, including life expectancy, it's a fundamentally important, like I would call it, a pillar of our requirements to live a basic healthy life. So there's a study that came out in JAMA just this past week that showed that you're twice as likely to get COVID PCR positivity if you're vitamin D deficient than if you're not. That was interesting, but that wasn't the exciting thing. The exciting thing came out in a steroid biochemistry molecular biology journal in a few weeks ago, and that was adding what actually was the active form of vitamin D, because they didn't want to wait for it to be metabolized in the liver and in the kidney. So they just gave vitamin D and added it to the best available therapy in the hospital, in the ICU, and looked at mortality in Spain. So this is in Spain, what that meant was that they would treat patients who already had pneumonia, who had viral pneumonia and were positive for PCR, and also got treated with hydroxychloroquine and azithromycin. So that's their standard of care. And then they were allocated to either vitamin D or no vitamin D, and then they tested. So they allocated it 2 to 1. That means 2 patients got vitamin D for everyone that didn't. And they required, 1 person required ICU admission in the vitamin D group, whereas half of the population required admission in the untreated vitamin D group. And then no one died in the vitamin D group, and 2 people died in the other group. And if you even look at the death rates are much lower than ours relative to hospitalizations, and that may be a function of the hydroxychloroquine, although it wasn't the purpose of the study. But it really begs the question, when you have something that costs pennies on the dollar, why isn't this the major public health discussion in the United States, or for that matter around the world? So you have all these relative risks that everyone knows about, the age, pre-existing conditions, the region, and so on and so forth. But we now have to add vitamin D and your inflammatory state. And our higher obesity rates are important, as is in Europe versus Asia. All these things will be teased out in the next 6 months. And these are the biomarkers. I don't want to get into this in detail. I do want to say that the chronic complications are going to be also difficult to tease out. The permanent lung injury is one thing, because if you have ARDS, you may get permanent lung injury. But all these other things can also be seen in patients with sepsis or patients with very poor overall conditioning. So if you're in the nursing home and you've been there for a few years, your chronic condition will get worse, and your time to recovery is going to be a long period of time. I think the interesting thing here is the last bullet, and that's the post-viral autoimmune state that may, in fact, even be induced by the vaccines, but certainly will be seen to a large extent when the population that's recovering now from their virus. The last slide I want to show is related to the difference between PCR testing and actual infectivity. Please understand, the PCR test does not care if it's positive, it does not tell you whether the particles of RNA that it's locating, that it's identifying, are infectious. There's no correlation other than in the timing of the test. So the earlier the test that you do, the more likely that it's picking up infectious particles. But over a course of many, many days, it will still be positive when you're non-infectious. So just let's understand that a PCR being positive does not mean that you're infectious, and the timing of these windows are fairly large. So we know that some people are positive 2 months after their return discharge home from the hospital. The other grim reality I want to raise just for a moment is the concept of mold. As we reopen all of our businesses and all of our movie theaters and all of our large buildings and all the buildings that have been vacated, this is there, and this is going to take its toll on the society over time as well. And you have to be very familiar with the reality that mold is going to be an issue as we reopen the society and the economy. And to that matter, Dr. Neil Nathan will be talking about this in November, and also going to be giving a webinar series later in September on mold. I just wanted to make sure you guys all knew, all of you that were practitioners understood that our toll amongst healthcare personnel was relatively lower than in Europe. So this is the data. It's roughly 1 in every 250 some odd folks that took care of hospitalized patients ultimately was deceased. But thankfully, these numbers are getting lower and lower as time goes by. The cumulative rate is 670 as of 2 days ago. So I always end this way, that a young physician likes to be fancy and likes a lot of different drugs for each disease, but the more mature physician or practitioner, dentist, oral surgeon, physical therapist, chiropractor, naturopath, et cetera, osteopath, so on. We know that if we can treat one drug for 20 diseases, that'll be a lot better solution. Thank you very much.
Well, thank you, Dr. Herskowitz, for a great presentation. And we have a few minutes left for questions, and I will read those off to you, sir.
Yes.
So let me go ahead and hit this. All right. So our first question is coming from Dr. Nguyen, and the question is, what is the link regarding stem cell and regenerative medicine again?
What is the link? The link in terms of the virus? Well, it's giving regenerative therapy, whether they're stem cells or exosomes. The whole point of it is to give an immune modulatory treatment. So the therapy is not directly antiviral, but it's immune modulatory. So it does reduce the pro-inflammatory state that the patients are in. So whether you're repairing a wound, or you're repairing an ischemic injury, or you're repairing a viral activation of the body that is out of control, stem cells appear to have an immune modulatory effect.
All right. And the next question is coming from Dr. Green, which is, does taking ACE inhibitors or ARBs affect the number of ACE2 receptors on the surface of pulmonary cells? Any new information?
I don't know the direct molecular answer to that, but I know that the ARBs and the ACE inhibitors have been found to not have an adverse effect, and in fact, the data suggests that they're protective. So, however the end result is, it seems to not have any negative impact.
Follow-up to that is, any new information on whether or not taking these classes of meds increase or decrease risk of infection with COVID-19?
Yes, the data, again, I wouldn't say that this is the main reason, but all the societies are in agreement. I can't say that the WHO carries a lot of weight here, but all the different societies on the cardiovascular side, I know, have reviewed the early data from Europe and in Asia and suggested that there was no increased risk.
And
so the same with ibuprofen. That was an initial controversy.
excellent. And last question that we have for time for today is coming from SC. Is there any statistical information on COVID-19 occurring with or causing herpes zoster infection or transverse myelitis symptoms?
Well, I have not seen anything other than in the two vaccine patients. But I can say that I would not expect the post-viral autoimmune state to come early, first of all. But more importantly, please understand that the majority of patients that have post-viral autoimmune states are not the sickest patients. They're the patients that have modest disease or cannot even tell that they ever had a virus. They just get sick later. And so when you have transverse myelitis or multiple sclerosis symptoms in the setting of a pandemic, one would have difficulty teasing out what would be the cause. But I think if we see an overall increase in these types of autoimmune disorders, then we will see them sometime in the next 6 months.
All right, perfect. So that's all time that we have for today. The last thing that I would like to mention to everyone is to be sure to subscribe to our email list at acam.org/interest and to get updates and education. So we also hope that you're going to be able to make the Collaboration Cures conference. Feel free to register via chat. You'll see I have posted that link up there. And Dr. Herskowitz, any closing remarks?
Yeah, and we also have a sort of a town hall type of session next week where we'll take questions more in one-on-one and devote much more time to them, the ACAM leadership. And I also want to thank all of our supporters and colleagues from the different fields, because this is a wake-up call on the society side to get into an integrative system of health, and it's also a time to build the collaborations that we'll need, because over time we have to be able to identify ways of making vaccines not the definitive answer to all of our woes, and hopefully as we develop more strategies to deal with this preventively, as well as engage it early, the better off the whole society will be.
All right. Well, Dr. Herskowitz, thank you so much for coming on, and ACAM members and visitors.
Thank you.
We appreciate it.
Bye-bye.
Bye.